I'm Stephanie Terzakis, and I am originally from New York, trained at Sloan Kettering Cancer Center back in my hometown, and then went off to Johns Hopkins, where I practiced medicine for about 10 years and becoming a sarcoma expert there, both in pediatric and adult areas, and working with both kids and adults in terms of our patients. And then came out to University of Minnesota about 3 years ago and have been working with our pediatric and adult patients with sarcoma since that time. And I am a clinician, so I'm in the clinic and I see patients several days a week and specialize in radiation therapy. And then other parts of my job also include the research side. So I've been a researcher in sarcoma for almost 15 years and have been really involved with the Children's Oncology Group, which is a group that develops national clinical trials, trying to really improve therapies for kids with all different kinds of sarcomas. And, I obviously am specialized in radiation treatment, but part of kind of the multidisciplinary team with our surgeons as well as our medical oncologists. And one of the reasons I became interested in radiation is I just was always kind of fascinated by the application of physics to medicine. I think it's really interesting to be able to use radiation as a treatment, to target tumors. I always knew I wanted to be an oncologist and work with patients with cancer. I had a few family members with cancer, and so when I went to med school, I knew that was sort of where I was going to head. But radiation specifically was an area that I decided to go into because it would kind of combine all my interests and really give me the opportunity to work with patients, that I continue to follow and see for years after treatment, and that was really wonderful for me. I think folks hear the word radiation and do get a little bit nervous about it, not knowing what it means or what it's going to entail. And really, all radiation treatment is just using X-rays to help target tumors and kind of using the power of X-rays to be able to really kill off tumor cells and help cure cancers. And then specifically in sarcoma, we usually work alongside with our surgeons and our medical oncologists to try to use, all the different treatments together to get the best results for patients, and to be able to kind of take the advantages of each treatment, put it all together, and have the best chance for cure. As a radiation oncologist, the process for us is we'll usually see our patient in a consult, obviously get to know them, understand the type of sarcoma they have, and then based on the kind of sarcoma a patient has, we will or may not recommend radiation treatment, just depends on the situation. When we do recommend radiation, which we do in most sarcomas, because it is very effective against sarcomas, we take the patient through a few different steps of the process to go from that consult all the way to treatment. And so after the consult, if we've made the decision that, we think radiation is best and the patient is comfortable going ahead, then the next step is actually doing a CAT scan, imaging, in order to image that area that we're going to treat. And it's a special kind of imaging appointment that patients have where it's really specific for developing the radiation plan. And so they come to our department, and usually patients are in a particular kind of position so that we can use the X-rays to kind of best get at the tumor and then also simultaneously plan to protect all the normal tissues that are nearby where we're treating. And so once the patient is in that special treatment position, then they basically get their CAT scan. And then at that point, we go behind the scenes, we take those images, and then we have an entire team behind the scenes. It's the physicians, we have medical physicists as part of our faculty, we also have dosimetrists that help us develop the radiation plan. And as a team, we work together to basically figure out how we're going to direct the radiation, through the machine, to land on the tumor, and then basically protect all the normal structures and tissues and organs that might be nearby where we want to get the radiation to. And so that's like a process we actually do over software and really sophisticated technology nowadays. And once we get the best plan we feel like we can get for the patient, then the patient comes back and to get the treatment started. And then each day is outpatient treatment, and the number of days kind of depends on your particular kind of sarcoma and diagnosis. But, you know, in general, patients come back and forth Monday through Fridays for several weeks. And treatments are, you know, usually, 5 minutes, 5 to 10 minutes. And during that time, you get basically the delivery of that X-ray plan that we did behind the scenes. And then, come in, go on the table in the position you were in at the time of the imaging session, get the radiation delivered, and then get to go home. And so that process gets kind of repeated each day over the course of those few weeks until we kind of finish up. And then usually at that point, patients might need another treatment like a surgery, or they may be, finished with their treatment. When we deliver radiation, there is a number of sophisticated pieces of technology inside the radiation machine. And so what we do is, like, it's kind of on a computer software. It kind of replicates what the machine can do. And so we essentially go back and forth to say, okay, we want the X-rays delivered this way. And that might come from multiple different angles that the machine delivers. And then because of the way the machine works, it can actually shield the other parts of the body and make sure that the X-rays that are coming out are shaped to the tumor. And so this way there's not excess radiation coming out going outside of the tumor. And that's why we have our dosimetrists and our medical physicists that help us essentially develop that plan and run the machine so that the X-rays that are delivered can come from these different angles and also be shaped in a way that protects the tissues nearby. Patients get almost like customized molds that help hold them in the same treatment position day to day. And so the mold is customized based on, one, where you're getting treated, and two, your body, basically. So if you're getting treated in the head and neck area, we usually do kind of like a Spider-Man mask. That is a plastic mask that goes over the head. And that is, again, specific to you. It's basically shaped to your face. And the goal of that is to hold you in the same spot within a couple millimeters, so that when you come in, day to day for the treatment, you're in the same spot that we program the radiation to go. And two, you can't move too far out of that spot while you're getting the treatment, because the radiation is incredibly precise, usually to within a few millimeters. And so, it's hard to hold that yourself without some help, and that's why we do those molds. Other folks that are getting treated, say to the leg, wouldn't get a mask. They might get more of like a beanbag type of mold that hardens and has their leg in a certain position that we know they could kind of hold day to day to day, and that makes it reproducible. The treatment, when we divide it up over those weeks, is actually the same treatment every day. And so the reason we have to do that is we can't give all the radiation dose at once. We have to divide it into multiple daily treatments so that you get just a little bit of dose per day. And in between one day to the next, your body can heal. The way that the radiation works is you want to give it every day in little increments, but you want to make sure you don't give too much time between treatments for the tumor cells to kind of recover. And so I almost describe it as you want to keep hitting at the tumor cells, and you don't want to give them enough time to repair. And so when you give it every day, you give a little dose, followed by a little dose, followed by a little dose. And that each day causes some damage to the DNA in the tumor cells. And so if you give too much of an interruption, then that damage can repair itself, and you lose the advantage of the radiation. You really want to continue to treat the tumor day to day to day to day, so that that dose can accumulate and get to a level that's enough to really eliminate the tumor. With sarcomas in general, I would say that we use the radiation in different ways. In some sarcomas, especially some pediatric sarcomas, radiation can be enough to eliminate the tumor along with chemotherapy, and you don't necessarily need surgery. In other kinds of sarcomas, you don't necessarily need chemotherapy. You could get surgery and radiation. And kind of depends on the sarcoma in terms of how effective the radiation is or what it's really used for. So when we combine it with surgery, the main goal of the radiation is really kind of to try to sterilize around where the tumor is so that when the surgeons take it out, they're better able to take all the cells out. And so it kind of helps get rid of anything microscopic that might be left behind after a surgery. Sometimes surgery comes first and we follow it with radiation. And the goal of that is, again, to get rid of any microscopic cells that might be left behind that maybe the surgery didn't get at all. In some cases where we're just using the radiation by itself and chemo, it's because those types of sarcomas are extra sensitive to radiation. So the radiation may be enough to get rid of them completely and result in cure. And so, I think because sarcomas have so much variety, as we know, really gets individualized on how we use the radiation and why we use the radiation and how effective it is and exactly what dose we go to. Radiation generally plays a bigger role in soft tissue sarcomas than it does in bone sarcomas. The exception to that is Ewing sarcoma, where radiation can be a treatment that we use by itself with chemotherapy without surgery. And patients can be cured with just a combination of radiation and chemotherapy with Ewing sarcoma. Osteosarcomas, one of the most common bone sarcomas, are very resistant to radiation. So the role of radiation is a little bit more limited in osteosarcomas. We still sometimes use it, depending on the scenario. But I would say that, when we do use it, we have to go to higher doses because it is a little bit more resistant to the radiation than the soft tissue sarcomas or Ewing sarcoma. When you're working with patients, I think one of the most important things is really kind of understanding their concerns and fears. I think cancer is a really scary diagnosis, and everyone might react a little bit differently, when they get that news. And so one of the things that I often try to think about is just, what is most important and what are the biggest concerns of the patient in front of me, and trying to really think about what those are and address those and talk about those with the patient. Some folks are really concerned about logistics. They have a family and they're working and, it's really overwhelming to think of all of the treatments and sort of change in their life that's going to happen. And so we really try to listen to that and really make sure that we focus on, getting them the information and the logistics that make that a little bit easier for them. Other folks don't care about the logistics at all. They're like, I'll come in anytime, any day, but their concerns are, more their children or, and their family is upset, and so every patient really has sort of really a different experience, I guess, with this diagnosis. And so I think trying to understand what that experience is and really trying to calm the fears around that and do what we can to make that process easier, I think is just at least one of the ways that we can help. Rain and Sarcoma is a nationally known organization. I mean, everyone who specializes in sarcomas knows about Rain and Sarcoma. And so having it in our backyard is a tremendous resource for patients because there's such a network with Rain and Sarcoma of folks that have had all that range of experiences. And so in terms of patient education, again, that's one of the things that I think is very overwhelming to patients when they first get the diagnosis, is just all the things they're now going to need to learn. to get through the process. And so knowing that there's that support network, right up front, that they're not alone in the process, that there is someone in the organization that is probably able to speak to, the concerns of that newly diagnosed patient. And then just even for those that aren't interested in talking with folks right up front, having the materials that they can go home and read themselves or read with their family and share with their family. I think it kind of covers the gamut to be able to get folks the resources and the information they need, and also have access to people and support if that is something that's going to help them get through the process. Some of the things that go into our decision making, as to whether or not a patient needs radiation, we look at the type of sarcoma that they have. So, going back to what we were talking about before, if a patient comes in with an osteosarcoma, bone sarcoma, we may be less likely to recommend radiation, over surgery. If someone comes in with a type of soft tissue sarcoma that's, large, that type of patient might get radiation. So we kind of look at the type of sarcoma, the size of the sarcoma, the location of it. And then we also look at the whole patient, and some patients have other health conditions that interfere with certain kinds of therapies, or being able to give certain kinds of therapies, or makes them not a candidate. And so, that's the other part that we look at, is really the patient's entire medical history, family history. Some patients come in with prior history of radiation and have had cancer before. And so that's another factor that we look at. And so we put all of that together to come up with that recommendation of whether we think radiation is kind of right for the patient and for that diagnosis. Yeah, so in terms of side effects, I would say one of the most common side effects of radiation is fatigue, just tiredness. And almost all of my patients get some level of tiredness through radiation. I think part of that is also coming in and out of the hospital every day for weeks. We know some of it has a biological basis where radiation can cause fatigue. But patients can usually still go on with their kind of normal daily life and daily activities. Some of our patients continue to work through radiation, and some feel, so tired that they decide, they're going to take the time, and just focus on their treatment. The other really common side effect is skin changes. And so I usually tell patients that, it's going to be like you've been out in the sun for a really long time. That's also a side effect that tends to accumulate over the few weeks. So you may not have that, in the first week of treatment, but maybe by the 5th week of treatment, you really start, seeing the area that we're treating getting a little more red and pink. Some patients continue to have those skin changes even after we're done for a few weeks. And at that point, it could peel like a sunburn or get really red, depending on where it's located and the dose that we're giving. And so those are kind of two of the most common side effects that I talk about. And depending on the kind of sarcoma and where we're treating, usually in the long run, there is some scar tissue in the area where we treat, especially if a patient gets surgery. And that can sometimes lead to kind of some stiffness. And generally, if it's kind of nearby a joint or something like that, almost like a type of symptom like an arthritis. So I would say those are the most common symptoms that we see overall in most patients. At the end of the day, radiation is really a critical treatment for us to get, the best outcomes possible, to get the highest rates of cure, and to be able to get patients back to their normal life, with sarcoma being, something that is behind them. And so, many of the side effects that we talk about are temporary and treatable. And so, in the grand scheme of things in terms of risk benefit, is we can, generally really manage the side effects of radiation. And really without radiation, we have a harder time getting rid of the sarcoma. And so the benefit of the radiation really outweighs those risks in most cases. And that's part of what we talk about. That's part of what we assess, when we see a patient, is making sure that radiation really makes sense for that patient and that the benefits are going to far outweigh, the risks that come along with it. So one of the things I always tell patients before they start, very common question is, should I continue to work or should I continue to go to school during radiation? And that's one of those things that I think is a highly individualized decision. But I tell folks that they should give themselves some time during treatment to realize that, if they want to take it easy during the course of treatment, for lack of a better way to describe it, they should. Some folks really want to continue to work and sort of carry on with their normal daily life. And that also is okay. I think it really depends on what is going to keep the patient feeling most comfortable, during the course of the treatment. And I tell folks to just really listen to their bodies over the few weeks, because there are changes over the course of those 5 weeks. So the first week, folks might feel really good and energetic, but by week 5 may really be feeling run down. And so to kind of expect that and plan for it a little bit and give yourself some flexibility to really listen to your body during that period. I usually do encourage my patients to continue to be active to whatever they can tolerate. So lots of my patients, continue to go on walks, even if we're treating the leg or, something where there's some nervousness around that. But, keeping some activity up, I think really is helpful from the point of view of self-care. And then many of my patients, really choose to bring someone with them to the appointments, kind of when they come in and out every day, whether they have someone drive them or just have a friend who's there for support. And we also encourage that if that's something that, is just helpful, again, to feel like you have the support that you need to go through a treatment like this. So I would say one thing to know with radiation is that it is outpatient. You're usually in and out of the department, in about 20 to 30 minutes. And so, I think, one of the things at least we try to do in our clinic is really listen to the patient's preference time so that they can develop a routine every day over the course of the several weeks that really works for them. There's a predictability to it. Most patients prefer to have the same time every day so they can schedule their day around that. And if they are having someone come with them, they can have that be predictable. And so that's definitely something we try to accommodate, especially because the patients, can come in, check in, get their treatment and leave. And it doesn't have to necessarily disrupt their entire day. They can plan for it. On the other hand, again, we also are pretty flexible because the treatments are pretty short. And so there are other folks that need more flexibility in the day, or maybe they want an early treatment on Friday so that they can leave for the weekend. And so I think one of the things to be aware of with radiation is that, there's some predictability and there's also some flexibility in the outpatient realm of that treatment. Yeah, I usually tell folks that recovery from the short-term side effects is usually about 3 to 4 weeks. And so one thing I have, what I ask my patients to kind of expect is that even when we're done with radiation, the radiation actually continues to work in the body because the radiation causes some damage to the tumor cells when you're getting it every day. But when it stops, that damage is still there. And so the cells are kind of still changing in the body, even though we're not giving radiation anymore. And so sometimes some of the side effects actually come a couple weeks after we're done, like the skin changes we talked about. Those are changes that, the redness from the radiation might actually peak about 1 to 2 weeks after we're done with the treatment. Kind of like when you go out in the sun and then you realize you're sunburned a day later, And so there's a little bit of delay on that. But then usually at about 2 to 3 weeks, folks start feeling better from those shorter term side effects. And so I usually tell my patients that about the 4th week, they should really feel like they're really turning the corner. And so that might not be that everything's gone, but that there's improvement. And then those improvements can honestly continue for months. So the tiredness, for example, my patients continue to feel less tired even up to a year after radiation. And so that recovery just, continues over time. So there's sort of some different follow-up schedules depending on the kind of sarcoma you have and the treatments that you've had. I would say, in general, most patients are seen back about every 3 months in that first year after their treatment is done for sarcoma. And we're usually getting some sort of imaging like a CAT scan or an MRI, and sometimes both. And that's to both look at the area we treated and also to kind of scan the rest of the body to make sure we don't see anything new. There's also a PET scan that is sometimes done for certain kinds of sarcomas. We don't necessarily repeat the PET scan, every 3 months, but sometimes we'll get a PET scan after you're done with treatments just to make sure that, we don't see anything new and that everything we've treated looks like it's essentially gone. One of the other, I think, important things for patients to know is that, many folks that are involved in treating sarcomas are also heavily involved in research, to really investigate how we can continue to make these therapies better and better for patients. And so I think it's important for patients to, maybe ask about that also in consults, whether there's any trials that are available for them or anything that is important for them to know, just in terms of new research that's coming out, because we're really learning all the time, about sarcomas and their differences and what works and what doesn't work. And so I think that would be something that patients should just be aware of, that many of their doctors are involved in actually, researching these as a career, in order to try to, ultimately cure more and more, patients with the treatments that we have and treatments that have yet to be developed.
I'm Drew Holm. I'm a physician assistant that's been working in oncology for just over the last 4 years. I'm from the Twin Cities area. I have a passion for patients, I have a passion for people, and I have a passion for cancer care. And I'm here to help as best I can for patients that will be going through chemotherapy at any point in the future, and to hopefully ease any of those anxieties and those questions that they may have moving forward. So chemotherapy, when I do my educational sessions with my patients, I tend to try to break it down as simple as possible for them. Chemotherapy is what we consider cytotoxic, so whatever cell it touches in your body, it's going to affect. I tend to use a term with my patients that chemotherapy is like a train running through your body, and anything it touches, it's going to affect. So that not only includes the cancer cells, but it's also the good cells, which can give you various side effects depending on the type of chemical that it is. Patients tend to tell me that it's poison, which it essentially is, but we have gotten pretty good at giving it now. So in controlled doses, it can be very effective against certain disease states, especially sarcoma. Chemotherapy can be extremely helpful when it comes to cancer care, and most of the time it is. So in terms of the chemotherapy, it attacks the cancer cells, and these drugs have been around, most of them have been around for a very long time, and they're very effective against the treatment. Some of our disease states we see relief of their symptoms within days of receiving the treatment. There's been multiple studies for a very long time about the dosages, so I get a lot of questions about, well, what's the dose? Or, am I getting a high dose? And I explain to the patients that every treatment is different in terms of the dosaging, because that's what we figured out the human body can handle. So at specific dosages for the human body, chemotherapy is extremely effective in terms of killing meaning destroying the cells of the cancer. And what cancer is overproduction of cell growth. It is out of control. The body is not controlling it anymore. So when we can really hone in on affecting the treatment, that's what chemotherapy does. It kills the cancer cells. And when it does that, we see positive effects. Relief of symptoms, which include pain, shortness of breath, various rashes sometimes that people get with their treatment. increase in energy over a period of time. Gaining weight, because when you have cancer, you tend to lose weight and you're not feeling very well. So all of that are the positives that come with the chemotherapy. So we always want to make sure that we're covering the risks. But anytime I'm speaking with a new patient, I want to make sure we're highlighting what's the positive of doing that. And depending on what situation the patient's in, a lot of the times they say to prolong life, to help you with your symptoms, or to cure you so that you can get through this bump in the road in your life and move forward. Chemotherapy can be administered in multiple different ways. The most common is usually through what they call a portacath. So it's a device that they put within the chest wall, just underneath the skin, that's connected to a vein underneath the clavicle or the collarbone, which then that vein connects to a bigger vein, which then connects to the heart. So that's one very common way. The other way is through a peripheral vein, so a vein in the arm, which we do with some patients depending on how often they get the treatment. Every so often, depending on the patient's what's the word I'm looking for, risk when it comes to maybe putting a port in, because it is a surgical procedure that sometimes we do what's called a PICC line, which is just a surface catheter that has 3 different access points, and they usually put it underneath the bicep area. Every so often they do intrathecal chemotherapy, which is in the cerebrospinal fluid, which is the area that covers the spinal cord and the brain. So they do like a lumbar puncture to give it that way. But I would say the most common ways are through a peripheral vein in the arm and also through a port device in the chest. Those are the most common that we see. So it can be given orally, depending on the disease state and the type of drugs that are available. So yes, you can be given oral chemotherapy as well. Risk for chemotherapy will depend upon the type of chemotherapy that you're getting. They can range as far as breakdown of skin and nail beds to developing a leukemia later on in life, depending on the type of chemotherapy that you're receiving. So it's a very broad range of risk factors that coincide with receiving chemotherapy. I think the most common ones that that the general public thinks about is feeling nauseous, losing your hair, breakdown of skin and nails. Those are side effects that cause risk factors, but other risks that are associated with chemotherapy include long-term effects on specific organs, your eyes, your ears, in terms of your hearing, kind of fertility problems as you get older in life, depending on how young the patient is when they receive chemotherapy. And then, as I said earlier, sometimes you can develop a blood cancer later on in your life because of the chemotherapy, because of how much it affects the bone marrow when you receive it. So in terms of risk factors, it really depends on the type of chemotherapy, but they all pose various risks, and that's why it's important to ask your doctor what types of risks am I going through when I receive each type of chemotherapy, because they're all different. After patients complete their chemotherapy, so for instance, if they're a curative state, meaning that their cancer can be cured, there are specific protocols that I and the practice that I work with specifically follow. We go off of what's called NCCN, or National Cancer Coalition Network guidelines, and they pretty much spell it out. And the general kind of outflow for following up with the various risk factors that we just talked about is, the further out you get from completing your treatment, the less of a chance you have of your cancer recurring. So within that first year to 2 years, we're seeing these patients every 3 to 6 months for physical exams. They're getting imaging every 6 months or so. We're asking them various questions, how's your energy levels, any new side effects that you've been noticing. And as they get further along in their follow-up, if they continue to not have recurrence, we spread those visits out, every 6 to 12 months. And the goal is to get those patients to 5 years. Once we get them to 5 years, depending on the type of malignancy that they have, but for the majority of them, they're coming in once a year after that if they would like to, or else they can continue to follow with their primary. But every time they come in, we're checking lab work, we're asking them various questions about side effects, giving them an opportunity to have a sit-down visit with us to really explain to us, how they've been feeling, what are the new things that are in their life, are there any new symptoms, just so that we make sure that we're not missing anything. As a physician assistant, I'm a licensed provider, so I have the ability to prescribe medicine and see patients. A lot of the times when you are receiving treatment from a specific place, a clinic, a facility, there's typically protocols for who you should be contacting and how the process works. So for instance, the place that I work, we have a 24-hour, 7-day-a-week number that patients can call if they're not feeling well. I have same-day openings to see patients, and when I do see them, I'm going through each of the body systems, asking them about specific questions about the symptoms that they have and the symptoms maybe that they've been having that they're not mentioning to me. And I have the ability to prescribe medications. A lot of the times, especially in chemo care, we like to give what they call IV hydration. So basically IV water into the veins to help really flush out any remaining chemotherapy particles, to flush that out of the system, to rehydrate patients, because that's a very important aspect of receiving treatment, is that you can become dehydrated very easily. And so we utilize fluids, different medications, and also the time on the schedule to help patients. So when patients, my advice would be for patients that are not feeling well is know the protocol for the place that they're at, make sure that they have those phone numbers on hand, and knowing, what are the things that I can wait on, what are the things that I need to be seeing right now, do I need to be seeking immediate attention at emergency rooms or places such as that. So. I think the biggest thing that I come across that I would say is something that we need to be talking about is intercourse with loved ones. We want to wait at least 48 hours after they have chemotherapy, just because we don't know the crossing of bodily fluids. Other than that, kissing and hugging is fine. Using sinks and toilets and other things that a loved one may be using after they have chemotherapy is totally okay. I think just the big thing is let's make sure the home is clean, just because that's good in general for preventing or reducing infection risk. And then we want to just make sure with intercourse that if we're going to engage in that activity, we want to wait at least 48 hours after they have chemotherapy to make sure that we're ridding of those toxins from the body. In terms of receiving treatment, most of the places that, especially outpatient clinics, will have their own infusion center. An infusion center is where we have multiple, usually comfy chairs, poles with wheels on them where the chemotherapy is administered to the patient. There's also nurses in there typically that are hooking the patients up to the treatment. So in regards to receiving chemotherapy in the outpatient center, it's going to be in a controlled setting at a clinic where there's providers, nurses, and various resources for the patient to be able to give them the treatment. And when I say outpatient, I mean they go to the infusion center, and then when they're done, they go home. And then there should typically be follow-up protocol for when to come back. If a patient is really sick, or depending on the type of chemotherapy, we may sometimes give that inpatient, so in the hospital sometimes is another setting that we give chemotherapy. Why would you be going to the hospital to receive chemotherapy? Because there are specific chemotherapies where we need to be monitoring labs, pretty closely, sometimes every 6 to 8 hours. Sometimes patients are really sick and they need 24-hour care when they're receiving their chemotherapy, and it gives us a more controlled setting than just the outpatient center where patients will go home when they're done with their treatment. So there's really only 2 places currently that patients receive chemotherapy, at a controlled infusion center in a clinic, or at the hospital as an admitting patient. The third way to administer chemotherapy in a certain setting, not just in the infusion room as an outpatient or in the hospital as an inpatient, is also orally. So patients can administer their own oral medication at home. And there's typically follow-up protocols for that. And the nurses typically at the facility that they're receiving treatment tend to give direction over the phone with that, but oral chemotherapy can be given at home and can be self-administered. Length of chemotherapy and the duration will depend on the drug and will depend on the diagnosis. Sarcomas, for instance, the treatment is typically every 2 to 3 weeks is when I see how often they get their chemotherapy. Once every 2 to 3 weeks, but I've seen weekly, so once a week. And that ranges from treatment. So there are treatments out there for chemotherapy in general that can be once a week or 3 days in a row, once a week, anywhere to once every 3 months that they're receiving the treatment. So from a generic standpoint, it will depend on the diagnosis and the drug that they're receiving. And the majority of treatments are anywhere between, once every 2 to 3 weeks, I'd say the majority of chemotherapies are given. I think what's important for patients to know is that it's important to do kind of daily healthy life things for everybody, whether you have chemotherapy or not. We want to make sure that we're getting good sleep, at least 7 to 8 hours a night, going to bed at the same time every night, getting up at the same time every morning. We want to make sure that we're having a well-balanced diet. So I always talk to my patients, I always get questions about what food should I be eating or not eating, and there's really nothing that patients have to have, or there's nothing that's going to make your cancer worse or your treatment less effective. There's a lot of rumors out there in regards to that, but we want to be well balanced. We want to have a good amount of protein in our diet, carbohydrates, fats, fresh foods like vegetables and fruit. If there's anything that I want them to eat a little bit more of, it's protein, just because when you're not feeling well, you're not eating as much and you lose muscle mass. So we need protein to help with that, build that muscle mass up. So that's something that's really important. A good exercise. So I encourage my patients at least 30 minutes of walking a day. I want them up on their feet. I want them moving, so exercise as well. And filling their day with things that give them joy. Reading a good book, doing puzzles, spending time with loved ones, filling their day with things that will keep them happy and moving forward. So those are really the 4 things that I want them doing. If they do those things leading up and during their treatment, they give themselves the best chance to feel as good as they can. I also want them drinking a good amount of fluid, free fluid. I like to focus on water. Sometimes Gatorade and Powerade, if it's sugar-free, is good for them. That doesn't include caffeinated coffee or pop or alcohol, but those things can be consumed just in moderation. So I want them consuming a good amount of free fluid, about 32 to 64 ounces a day. If they do all of those things, they give themselves the best chance to feel as good as they can during their treatment. And it's just being as consistent as possible. I think the biggest advice is knowing that, it's going to be okay. Cancer care is hard, and having cancer is hard, but being on a good team, knowing who you're seeing, and just knowing that it's going to be okay. We're really good at giving chemo now. We're really good at knowing what to do. We have protocols in place, or at least where I work. I can speak for where I work. I always tell my patients, you're not going to receive any better care anywhere else. And I just want patients to know that it's okay to receive chemotherapy, and they're going to be okay going through their treatment, and they're going to be supported. And with all of those special medicines that we're giving, follow-up that we're providing to them, that they, once we get them into a good routine, that they're going to be feeling okay, and that it's all going to be okay moving forward. And I think that's really important to encourage patients, no matter what diagnosis they have, that we do have options for them. We do provide hope with our treatment, and I want them to know that the hope is there for them.
My name is Christian Ogilvie. I'm an orthopedic surgeon, and I work with sarcomas, both bone and soft tissue sarcomas. I treat these in the extremities and work with our medical oncologists who do the chemotherapy and our radiation oncologists who do the radiation. So it's my job to take out the tumors and often to do the biopsies. So I'm the surgeon in that group of the 3 pillars of treatment of the soft tissue and bone sarcomas. As a surgeon, I'm often the person who sees them initially. They're sent in orthopedic surgery. They're often sent in by the community orthopedic surgeon who gets referred bone lesion or a soft tissue mass, and then they'll send them to us. One of the first things we do is come up with a list of possible diagnoses based on our exam and the imaging. And then if we think we need tissue diagnosis is what we call it, we will do a biopsy. We need to get a little bit of tissue for a pathologist so they can look at it under the microscope and tell us what we're dealing with. And so for soft tissue tumors, I often do that in the clinic with a little local anesthetic. And for bone tumors, we usually take people to the operating room and make a small incision and get a sample of the bone. So it's my job to do the biopsies and make the initial diagnosis. And when these turn out to be cancerous tumors, it's usually my job to go and take them out later. Sometimes they'll have some treatment in between, such as radiation or chemotherapy. And then I work with the providers that do the radiation chemotherapy, and we talk every week, and we decide, usually they decide when they're done treating them, and then in the case of radiation, they might need a little rest for the skin to recover. I usually do about a month, give or take, and then we take that out. And the chemotherapy, that can affect the bone marrow counts, your red blood cells, white blood cells, your platelets, and we want those to recover so that we get successful surgery and good healing after surgery. So, we plan the surgeries after the patients have a little respite and recovering from their initial treatment. For many of these tumors, I'm also the person who is following the patients for years afterward to make sure that the knee reconstruction I did is still working, but mostly to make sure that the tumor is not regrowing. But any regrowth of the tumor, aches and pains, other things that have to do with the area where the tumor was, they're coming to see me and talking to me about that. So the diagnosis, the getting the tumor out, and then following people for a period of time to make sure that the tumor doesn't spread or regrow. And often I'll be following them with the medical oncologist if that person was part of their initial treatment. So our main test for the soft tissue tumors is an MRI, and that doesn't tell us what it is, but it'll tell us where a tumor is and its relationships to the other structures. For example, as I mentioned, I often like to do biopsies of these tumors in clinic when I first meet the patients. But sometimes the tumors can be in a place where it might be dangerous or uncomfortable to biopsy them. If they're underneath the sciatic nerve, I don't want to put my biopsy needle right through that nerve. Or if there's a large artery there, for example, we don't want to injure that artery and have a bleed and some swelling. So the MRI will tell us where all these anatomic structures are, and we can decide where is the best route to do the biopsy, and that helps us with surgery to be prepared to know what structures might need to be removed. We can talk to the patients about that, and what things we need to watch out for and be prepared to deal with during surgery. So the MRI is number one for soft tissue masses, and that's a procedure planning tool. It gives us some idea of what it is. We can develop a list, but it's not precise enough to avoid a biopsy typically. X-ray is a number one starting thing for the bone tumors, and we also do MRIs for those. And the X-rays give us a sense of whether there's some bone destruction, whether the body is trying to make new bone to contain whatever's going on. And there's some subtle things about those interactions that allow us to characterize the tumors and say, oh, this is most likely this type or that type. And again, that helps us just be prepared to talk with the pathologist about what they're seeing. We want to make everything to fit and make sense. We don't want the pathologist to say, well, I didn't see anything, and it looked like all normal tissue, in the X-ray and the MRI to say, well, this is definitely a tumor there. That means maybe the biopsy was not successful at getting the right tissue. So we want everything to make sense, and we use all those imaging tools as part of that set of information. So X-rays and MRIs are number one. We occasionally do a CAT scan, a CT scan. They don't have a big role. Ultrasound is becoming more popular, but it's often difficult to interpret, and it doesn't give us specific enough information to use by itself. It has some limited roles. It may be confirming that something is not a tumor, but it is not a great standalone imaging modality to help us understand the tumors very well. So, a PET scan is something that's being used more and more nowadays. It shows your body's use of glucose, of sugar. That's all it does. But yet it's kind of treated as this magic tumor detecting tool that will find everything. It can detect tumors about 1 centimeter or larger, but it is a sugar molecule that has a little radioactive particle attached to it, and that gives off a particle that can be detected. So it goes to areas of the body where they're using sugar a lot, and cells that are dividing rapidly, that are very active, will use more of the glucose. The heart uses a lot of glucose. The brain uses pure glucose. So those areas will really light up. If you have an injury that's healing, you'll see more uptake on the PET scan. So the PET scan is not specific to any particular type of tumor, but it will check not just the bones, but the soft tissues as well. For example, an osteosarcoma, it can not only spread to the lungs, it can spread to other bones. So we used to do a scan of the lungs and a bone scan. And now, instead, we do a PET scan, and we overlay that with a CT scan, which allows us to see the fine detail. So they take all that PET image information, and they superimpose that on the anatomic detail of a CT scan, and then we can see, oh, there's this little fuzzy blob of something going on. Where is it? Oh, that's your left fourth rib. You know, I can see that really well because I have that CT scan anatomic information right up against it. So it's something I can do from the top of the head to the tip of the toes, and not just look at the bones or not just look at the soft tissues, but we'll really do everything. And it'll show me where the term we use is metabolically active cells are, down to a pretty small size. So it's been a nice tool, and it's starting to get used more and more. There are some tumors that are not particularly active on the PET scan. Chondrosarcomas are really hit and miss. You know, the Ewing sarcomas and osteosarcomas, it seems to pick those up very well. So as we use it more, we learn what tumors it's really good for and what tumors it's perhaps less likely to pick up. But yeah, it's a much more common tool that we're using these days for many of the sarcomas. Most of the blood work we do, or other type of labs, it will be done by the medical oncologist for a variety of reasons. I don't order too many labs, and when I do, it's usually I'm trying to rule out an infection. And so that may be part of the process of saying, well, what's going on in your bone? Is it an infection? Is it a tumor? Is it something else? So you might get some labs to rule out an infection, which might be your white blood cell count and some measures of inflammation in the blood. There are some other labs to rule out bone marrow cancers that are really good labs that we might order, especially for adults with holes in the bone. One of those is called myeloma, and that's not a sarcoma, but it's something that we commonly see, and we have to, you know, it's part of the process of sorting all these things out. You know, what do we have going on here? Some of the labs that the medical oncologists do will be in preparation for giving the chemotherapy. There's some chemotherapy agents, for example, those used in osteosarcoma, that can affect the heart. So we want to see that your heart's in good shape from the get-go, and so you'll have additional tests to make sure the heart is whatever it is, you know. And if you have issues of the heart, then maybe that medication is not the best one for you. But we have to answer that question before you get a medicine that could have some toxicity to the heart. So the medical oncologist will do a variety of things, and they'll do them, I don't know if I mentioned it, but some of the chemotherapies will decrease your blood counts, or the cells produced by the bone marrow, white blood cells, red blood cells, platelets. So there's levels where those could be dangerously low, especially the platelets, which do blood clotting, but we want to monitor those levels because there's medicines you can give to raise the levels. So the medical oncologist will check and see where you are, where you're starting, and as they give the medicines, they'll see how low those things go, and they'll want to, before they give you the next round, they want to see that they come back up to a good range before they give you any additional medicines that might knock them down. So, monitoring during chemotherapy, preparing during chemotherapy is where most of the lab work's done. Most of the time people are coming to surgery to get their tumor out. So it's exciting. We're anxious to get that thing out of there. Usually have to come in a couple hours before surgery and they'll get you all changed up. Except for the youngest kids, you usually have an IV placed somewhere. And then the nurse will do a little wash of the area of skin that we're going to be working on, and they may even shave the hair off of that area. It's just easier to sew it closed if we don't have to deal with the hair in the way. And then I'll come in and see the patient a little bit closer to the time of surgery and answer any final questions. Usually we've had some meeting in not too far before that where we've kind of gone over exactly what we're going to do. But I'll answer any questions that may have come up. I'll put my initials right on the spot or close to the spot where we're going to be working, and we'll have them sign the permission form for the surgery, the consent for the surgery. They'll meet the anesthesiologist who's going to do the anesthesia. Some people, it's typical to have general anesthesia where they're completely asleep and have some type of a breathing tube. Many people have nerve blocks, and there's a whole team that will do that. And nerve block, for example, for work on the arm, they might give you an injection just above the shoulder that'll numb up the arm. And we have some things that'll numb up the arm for a day or a day and a half so that when you wake up from surgery, it doesn't hurt at all. And much of that pain can be, some of the worst pain is in the first couple days. And if the arm is numb for the first couple days, that's really helpful for some people, especially those that are already on narcotics, and we don't want to have them on too much, or those who don't tolerate the narcotics very well. So not all, but some surgeries we can do nerve blocks, and that's done up front there as well. So you'll be taken care of by a nurse in the recovery area. And then after surgery, when you wake up, the medicines they give you usually make you forget the time that you're rolling back into the operating room and coming out of the operating room, even though you're technically awake. But when you start remembering things, most of the time people are in the recovery area, and there's a nurse taking care of them there. They're monitoring their IV fluids that are going in, and they're making sure that they're comfortable. For the soft tissue tumors, the superficial tumors, it's mostly getting the skin to heal up. And for people who've had radiation, sometimes that can be a little tricky because the skin healing is more slow. And when the tumors are superficial and right underneath the skin, that can affect the blood supply to the skin. So we worry about skin healing in people who have been radiated. So often we'll send them home with a drain in that area, and we'll take that out a week later. And the radiation causes some constriction and scarring of the lymphatic channels in the small veins, and it's their job to take away all the extra fluid. Well, in surgery, we damage these cells, we create a lot of extra fluid in that area, and because of the radiation, it doesn't come out of that surgical field very efficiently, and so it can build up. And almost everyone who's had radiation prior to surgery will get a fluid collection. So we'll leave a drain in for a week to give that skin a head start at healing, because it's going to have to deal with a little back pressure from some fluid in most cases. And as I said, the superficial tumors, that's more of an issue. If the tumor is deeper underneath the muscle, and I can close a little layer of the muscle covering over that, I can protect the skin with that as well. So for radiation, the skin takes a little longer to heal. It's more in that 3+ weeks. We monitor that closely, and they say they may have a drain that's coming out early. And then we want patients to get into physical therapy to kind of work with if they've lost part of a muscle, to work with the remaining muscles that might support the function that was impacted by the surgery. For the bone sarcomas, often we are putting in a big metal implant, and so we really want to protect that from any infection. So we're doing this multiple layer closure, and sometimes those patients have drains and sometimes they don't. Often they will start physical therapy very quickly. We do a lot of surgery around the knee because there's a lot of tumors that occur around the knee. We think that's because the growth plate and the thigh bone, the femur bone just above the knee, is the most active growth plate in the body with lots of cell divisions. And we think having lots of cells dividing may be one of the points that puts the cells at risk for having a mistake when they divide and then becoming a cancer. So we wind up doing a lot of surgeries around the knee, and some of those are knee replacements. And so we have our therapists who are really good at working with knee replacement patients, work with these patients that have a replaced knee plus a little bit of bone, a knee replacement plus, but getting them moving and working on the strength, but that does take time. Some patients, because of the type of implant they have, we really don't want them to move or don't want them to put weight on it for a little while, and that's hard. Many of our bone sarcoma patients have to get back into chemotherapy in a couple weeks, and that really slows down the muscles getting strong again, and we really want them to work on their motion so they don't get stiff, but many of them, they just don't feel completely normal, and they're not able to get the strength and the comfort getting around until they're done with the chemotherapy. So it's a little bit of a long haul in some of these cases with bone sarcomas. The anesthetic agents can cause some nausea, and the pain medicine, the narcotics can cause constipation and itching. So there's a medication side effects of the medications we often use. The surgery itself, I mentioned that those who had radiation beforehand, we worry about the wounds coming apart and then subsequently becoming infected, which is a real nuisance. That's more worrisome in the thigh than other parts of the body. So there's things that we do to try to prevent and prepare for that. And we have a whole protocol of handling the skin and what type of sutures we use and things like that. So for the bone sarcomas, it's mostly being prepared to do therapy and getting that limb moving again, and even doing that to some degree with the chemotherapy. I think that's the toughest thing to get people ready for. So I am very interested in imaging. I look at all the imaging, and I look at that before I look at any of the reports. Even sometimes the CAT scans of the chest, I'll do that. But certainly the imaging where the primary tumor is, and I'm really responsible for getting that tumor out at some point. So I need to be familiar with really every detail of everything that's going on there, all the anatomic structures, every aspect of the tumor and the inflammation surrounding it. I kind of need to know where that is. So because of my orientation as a surgeon, I often will look at those things and think about how I might treat that. So I've done the surgery in my mind before I've met you and before we even know it's a cancer most of the time. I think about like, well, what is this? What do I have to do to take this out? And that's just right where I go to. And so sometimes I'm maybe not the best at remembering patients' names, but if you put up their MRI, I will know exactly what they have. And I'm like, oh, yes, I remember this person. So those are all stored away, and I look at those before surgery. I have this list of people that I'm operating on 6 people tomorrow, and I can't quite remember what they all have, but as soon as I pull up their imaging, I'll know everything about them. So that's my association, and that's where I go to. So I look at the imaging, that's how I prepare. I think through the surgery, and as I mentioned, the surgery is important for procedure planning, for the surgery planning. We need to know where all those anatomic structures are. I think about how I'm going to handle everyone that's in the way, everyone that's close to the tumor. What do we do with this one? Is it going to be okay? Do I need to rebuild it? Is it going to be partially removed? Do I need to replace this with something? Do we need, if I'm taking out stuff, does stuff need to go back in? So do I need a metal implant? Do I need a bone graft? What type of bone graft? Do I need a custom implant? That's going to take longer. Maybe I should pull the trigger on that right now. It's going to take 3 months to build. They're going off to chemo for 3 months. I cannot order that 2 weeks ahead of time. I need to make that decision up front. And so there's a lot of thinking through what it's going to take to do the surgery. And so wearing the surgeon hat, that's what I'm constantly doing when I first see someone. And then other than reviewing it and thinking through it, just it's a very focused mindset, so I try not to have other things that are distracting me during the day. I don't, in between cases, I think about the next case and, make sure I'm physically feeling good, but I try not to do too many other things. It's really a laser focus on what I need to do and what needs to happen for things to go as well as they possibly could. And when I see people, I fully expect that we're going to be able to take care of them and cure them. And and there might be some trade-offs. They might lose part of a muscle. They might have to have a bionic knee, but that's what I expect, and that's why I do this. It's because there's so many people that I can help and make a huge positive impact on. I've looked at other fields, some of them cancer-related, and I wasn't satisfied that I could do enough or that I could have a big enough impact. It seemed a little bit too much out of my hands, and so that's one of the reasons I gravitated to surgery, and orthopedic surgery fit my interest and skill set. But I think every patient, I feel that we're going to be able to take care of them and walk them through it. And my foundation for going into medicine is really based on that really desire and interest to sit down and one-on-one with somebody, talk about something that's important and serious, and that I can do something to help them and help them through it, and not just do the technical side of it, but help them understand what's going on and do the educational side. So I want everybody to come in and say, oh, I'm going to learn about this, and they're just going to take care of us and walk us through whatever needs to be done. And that's why I love doing it, is because that really works out well the great majority of the time.